Good morning. One more time. Hello, everyone. This is Alraies from CVI 2023. I'm really privileged today to be with Dr. Basir to talk about an important topic, which is cardiogenic shock. Babar, thanks for being with us.
Thank you, Chadi.
So you've been a big expert in the shock space, and there's few trials coming up, few trials happening now, and I was surprised today when you asked the audience how many of you have a shock protocol in your hospital, and only few hands were raised. That's a concerning thing, I think. So maybe it's because of the complexity of the algorithm or something. So let's kind of break down the issue and see where we can start with a shock protocol.
Yeah, I think what's important is that I think we've realized that clearly these patients are very demanding on a healthcare system. And I think what healthcare systems are noticing is that when we have a team-based approach using protocols and shock teams, that we can organize the care for very chaotic and disruptive patients. But it is surprising to me that there were so few people that actually raised their hands for that. And I think some of that is just related to kind of nuanced care within the community. I think these concepts, even though they've been talked about at an academic level for some time, I think just takes time to diffuse them within community-based practices. But what's been really encouraging is that I think there is kind of a slow and growing adoption of the use of these shock protocols and teams. And I think the healthcare systems are actually realizing that when they provide high quality care for these patients, despite being how sick they are, that they're able to, actually obtain good outcomes. But the start of that comes from evaluating your own outcomes, realizing that there is an actual problem, and that we need to try to come up with a solution.
Absolutely. So with your protocol that you developed at Henry Ford and becoming like nationally recognized, is it something is evolving, or is it something just happen to develop at one time and revisit once in a while?
Yeah, no, I think it's definitely evolving. So we started off the shock initiative really focusing on AMI cardiogenic shock and the use of Impella. And it was important for why we talked so much about Impella. Well, 99% of cath labs presently have the ability to put in Impella, but very few centers have the ability to actually put in ECMO independently without the significant involvement of other subspecialties. And so then there's clearly a delay gap in terms of treatment with ECMO and other devices. And so we really kind of want to I think that is ultimately going to be the next stage as well, and I think we're actively working on how to get to that. So we started the ceramics trial, which is going to be a second version of NCSI, but only in sites that have the ability to escalate care, whether it's through cardiac surgery, critical care, or interventional cardiology, but they'll be able to do it rapidly. And we'll see what the outcomes are in those sites versus the general 80 pool of sites that we had in the shock initiative.
Yeah. So a few words about Protect 4. It's still evolving and recruiting at this point.
Yeah, so Protect 4, study in high-risk PCI with the use of Impella is over 50% recruited now. It's going to be the largest high-risk PCI trial that's ever been done. Dr. Greg Stone and the committee did a fantastic job with really looking at a lot of secondary outcomes, including AKI. There's a viability sub-study. My favorite is the right heart cath sub-study. And so we're going to just get a pool of information on high-risk PCI and when to use hemodynamic support and the outcomes associated between those two strategies.
Right. So I think it's one of the things that quote-unquote intimidating for some operator is the insertion of the pump.
Yeah.
But the most important thing is once they put the pump in, and this is one of the challenges we have, is when the patient go to the ICU, what happened there? Yeah. And every device has its own complications, so you have to be vigilant with all these nuances and know when to escalate either to ECMO or transfer to a center of excellence where the shock is their thing to do.
Yeah, no, I completely agree. I think the ICU management of any of these devices is more important than just the insertion technique, which goes back to your earlier point about really having the importance of a shock protocol and team within your institution so that there's a strategic management strategy for how these patients are treated, irrespective of who's on call and who's not on call.
Yeah. So is there a protocol part of your NCSI is for nursing education or managing the Impella or ECMO for these patients?
Yeah, so there's two things that are going on. One is ceramics is going to look at hemodynamic and management data, not just for the first 24 hours like NCSI did, but out to 5 days. And so that should give us a much clearer idea of what happens within the ICU. And actually a couple of my key interventional cardiology fellows, Sam and Hussein, are actually working on a trial called the Proctor MCS trial. And what they're doing is they're actually prospectively looking at complications with all MCS devices, because we actually don't know. When we look at them retrospectively, we say everybody had bleeding or everybody had transfusion, but a lot of that transfusion is actually consumption, and maybe some of that bleeding is not access site related bleeding, it's other bleeding because of anticoagulation. And so we're going to prospectively get a really clear idea of where these complications are occurring, with the eventual hope that we're going to decrease those complications.
It's very interesting and very intriguing to hear that still the shock protocols and management is still evolving, and it's like still we're not at the peak, even as you mentioned in your talk, as well as Naveen Kapoor. But we're going to learn every I think 3 months, 4 months, there's a new trial coming out and also new protocol coming out. But thanks so much for all the hard work that you and your team put together with Dr. O'Neill at Henry Ford. Watch these videos and others, please, on CVI YouTube channel. This is Chadi Alraies from Austin. Dr. Basir, thanks so much for being with us.
Thank you, Chadi.
Yep.